I'm going to take the liberty of sort of pulling this mic out and stepping out front so I can see my slide deck. I want to thank everybody for being here. What I'm planning on doing today is just giving everyone a little bit of an understanding about what this disease is and understand a little bit about the epidemic. And I'm interested to see in the room we have physicians, nurses, pharmacists, people with diabetes. So for some of you, this may just be an ABC and a recap, but I want to make sure we all start from the same understanding of what this disease is. And what is diabetes? Okay. Basically, it is a disorder of metabolism and fuel regulation. The body's inability to burn fuel in an efficient manner and all the resultant consequences that come because of that. It's characterized by an completely absent to inadequate insulin production by the beta cells of the pancreas. The beta cells of the pancreas, and the pancreas is an organ that sits behind the stomach in the very back of the belly. And in the particular islet cells, the beta cells are what produce insulin. Insulin is a protein and a hormone. Without insulin, glucose, or the blood sugar, the fuel of the body, cannot get into the cells to be used. Because insulin is required for glucose to move out of the bloodstream and into the cells for fuel. And when you can't use glucose for fuel, what happens? You have elevated blood glucose in the bloodstream. Okay? Everybody goes, okay, you got an elevated blood glucose. What are the consequences of that? The typical symptoms, what happens is when your glucose gets too high in the bloodstream, the body senses that and it has this desire to equilibrate concentrations of particles. So the body will pull fluid out of the tissues and try to dilute that glucose, those particles that are excessive in the bloodstream. When that happens, you have increased blood flow to the kidneys because of all the fluid. When you have increased blood flow to the kidneys, you have increased urination. Meanwhile, back where the tissues were, the muscles, the liver, the fat cells, all those things that lost their water are now dehydrated. That sends a signal to the brain to drink more. So then you drink to try to replete what you just took out of the muscles. Okay? And then, again, the cycle continues, and water moves into the bloodstream, increase. So you get this endless cycle, and in children and people with type 1 diabetes that I'll talk about in a little bit, this can be acute and deadly in a very rapid fashion, usually a slower process in people with type 2 diabetes. So these patients present with excessive thirst and urination. They present with blurred vision. They're fatigued. They're terrible. They just feel terrible. In the more severe cases, we'll have patients with weight loss. Why is that? Well, if you're urinating all your caloric source out through your urine, right, you have no way to keep fuel in the body and you lose weight. Not only that, a lot of times when these patients come to diagnosis, they're 10% dehydrated. So there's a significant amount of fluid loss in these patients. So these are the kind of significant symptoms we look for in patients with diabetes. They also have poor tissue healing. You can have sores, everybody's heard about that. Women can have yeast infections. All these things because the body's not working well. Okay? The biggest problem here is in type 2 diabetes, and we'll talk a lot about that, there may be no symptoms. There may be absolutely no symptoms at all. So if you're not in a relationship with a healthcare provider and you're not seeing anybody, this can go unchecked for a long period of time. The acute complications of diabetes, diabetic ketoacidosis. This is unique to patients with type 1 diabetes. What happens is, before the discovery of insulin in 1922 by Banting and Best, these were usually young children. They were dehydrated. If you looked at pictures from back in 1922, these children looked like they'd been through the concentration camp right before they died. It was a uniformly fatal disease. The discovery of insulin in 1922 and 23 earned Banting and Best the Nobel Prize because literally they put tissue back on these children. These children lived where they didn't live before. Because type 1 diabetes is characterized by an absolute loss of insulin, and I'm going to talk about that in just a second, these patients can present really, really quickly. And so a lot of times in children, the first presentation is a diabetic ketoacidosis where the body can't use fuel, it builds up acid in the bloodstream. These children can go into a coma and die. You will have 6-month-olds going through 10 diapers a night because they're peeing so much and will come in a coma to the pediatric intensive care unit, and some of whom will die. We do a better job, I think, at recognizing this now than we did before, but that's one of the acute complications. The other acute complication from diabetes is us. It's us as providers giving them medications that have the potential to drop their blood sugar so low that they get confused and again can go into a coma. And many of y'all will have heard of people who have had that, who have diabetes, and they've had to take glucose tablets. My patients in Nashville, Tennessee eat Snickers bars. Not the choice you should choose. But you know, this is usually due to insulins, certain types of agents that we give them. So these are the acute complications. I don't want to minimize them, but they are a small subset of what we're really talking about here, because this is what's happening. After insulin was discovered in 1922 and 1923, we thought, wow, cured this disease. Until you find out years later that all these patients with type 2 diabetes and type 1 diabetes were ending up having complications downstream. And that's what we do now, is try to treat these patients so that we can prevent these. There have been several landmark trials that say the following: if we can keep diabetes under control, and we can invest the time and effort to keep their glucoses at a certain range for a long period of time, we can markedly delay or even prevent some of these complications. And the way you divide these complications up is into small blood vessels and large blood vessels. Okay, so these are the classic diseases of the small blood vessels. Eye disease, called retinopathy. You get an inflammation in the back of the eye. The small blood vessels of the retina proliferate because glucose, when it's a toxin over a period of time, irritates the eye and causes what we call ischemia, which is decreased blood flow. So the eye responds and the retina responds by trying to grow all these new blood vessels. These new blood vessels are very fragile. They can rupture. You can bleed into the eye and you can go blind. If you're not seeing a regular eye specialist every year or two and looking for this, they are asymptomatic. And so a lot of patients, this is a key thing, is to have our eye care providers involved in their care. Secondly, kidney disease, nephropathy. Small blood vessels of the kidneys can be inflamed over a period of time. Again, decreased blood flow. That causes leakage of proteins and large molecules into the urine. And these are the patients who end up on dialysis. Nervous system, neuropathy. How many people have heard of people with diabetes who can't feel their feet? Again, same decreased blood flow to the very small blood vessels that serve the nerves in the feet can cause progression from a little bit of numbness and tingling to really painful tingling to severe pain to, guess what, I can't feel my foot anymore. And you know, if you don't think about it, right now I'm pacing back and forth and I can feel the position of my feet. Imagine what it's like to try to walk if you can't feel your feet. Imagine what it's like to try to drive an automobile if you can't feel your feet. And what ends up happening that leads to amputation, again, I'll talk a little bit about this, is a combination of the fact that you can't feel your feet, you end up having injuries to your feet, you end up walking in an abnormal pattern, put stress on the foot, puts it at risk of ulceration and infection, and then you have a complication of poor blood flow as well. Here's what we're learning now. Liver disease. You know, we didn't classically think about the liver as a target for end-stage complications, but we now have things like fatty liver disease and something called NASH, N-A-S-H, which is non-alcoholic steatohepatitis. That is basically cirrhosis of the liver from diabetes. Okay? So you have all these patients, and you know, it was all in the 1990s and the 2000s that we started realizing that these patients never touched a drop of alcohol, but they're coming in looking just like an alcoholic liver with liver failure. New in the news that a lot of you have heard about is, what are the effects on the brain? What are the hypoglycemic effects? People have recurrent hypoglycemia. What's that doing to the brain? And what about people who have chronic diabetes that's not well controlled, and even people who are well controlled? We think that now some of that damage to the very small blood vessels in the brain, there's a huge link to senile dementia and Alzheimer's disease. So now we're all of a sudden thinking we have a new area of research we have to figure out. Is diabetes putting us at risk of increased risk for Alzheimer's disease and end-stage diseases of the brain? Other chronic complications, macrovascular. That just means the large blood vessels. Now, the microvascular complications I just talked about are serious, but most of my patients with type 2 diabetes and most of the patients across the country, what we're worried about is this. 2/3 of the patients who have type 2 diabetes will die of cardiovascular complications. And when I talk about cardiovascular complications, what we mean is heart attack, stroke, peripheral vascular disease, which means blood flow through the carotid arteries and brain that could put you at risk for stroke, blood flow through the belly that puts you at risk for aneurysms, blood flow to your feet that puts you at risk of amputation because you can't perfuse and send blood and oxygen to the tissues down there. And of the heart attack patients, even the ones who survive, congestive heart failure resulting from a weak heart accounts for about 60% of the people who die of heart disease with type 2 diabetes. We know that diabetes is an inflammatory disease. It causes changes in those what we call endothelial cell linings of the blood vessels so that they are at increased risk of developing cholesterol plaque, inflammation, rupturing that unstable plaque, and having a clot form in a vessel delivering blood flow to a vital organ, whether that's heart, brain, even kidney. So just to talk about where we are, diabetes prevalence in the United States. This is 2010 Centers for Disease Control data. And Bob just mentioned this. We have 25.8 million people in this country, 8.3% of the population, and of those, 7 million are undiagnosed. What we have done better in the last 10 years is trying to shrink the number of people undiagnosed. The American Diabetes Association spends an inordinate amount of money about awareness, take the test, know the score, get to your provider, are you at risk, and I'm going to show some of that. So we have actually done a great job as a nation getting more patients diagnosed. But what we haven't done is stem the tide right here. This is the only chronic disease in this country growing at 7 to 8% a year. Now, prediabetes. We all know that the changes that go on in the pancreas and in the beta cells and in the tissues occur long before the blood sugar actually goes up, particularly in type 2 diabetes, not so true for type 1. Patients have these cellular changes. The pancreas is revving up its production of insulin more and more to keep track. And then finally, you meet this threshold for diabetes, either with something called a glucose or something called an A1C. But before then, we have a tremendous opportunity, and it's what we call prediabetes. And I remember sitting in Stuart Perry when we had the diagnosis of A1C for diagnosis. The Europeans don't like the term prediabetes, and the American Diabetes Association, our representative, said, we love prediabetes. We've preached prediabetes to the state legislators, to the halls of Congress, to everyone, and Stuart said, we're not getting rid of it. And it really is a call to action, but here's the 1,000-pound gorilla in the room. 79 million people in this country meet the criteria for prediabetes. And IFG just means an impaired fasting glucose or an impaired glucose tolerance. Bottom line, your glucose isn't high enough yet to make a diagnosis of diabetes, but a large percentage of these patients will become diabetic in the next 5 years, and it's a continuum. So this is our opportunity right here. Economic impact, $98 billion to $132 billion to $174 billion, and Bob pointed out correctly, $116 billion is in medical expenditures. You know, it's really, as you look at trillion-dollar deficits and numbers that are just too big for most people to fathom, what does $174 billion look like? And I think the most accurate way I heard this put, that is what the federal government spent in 1 year on the cleanup of Hurricane Katrina. Okay, think about that sentinel event in American history, the flood, and how much it took. That's what we're doing now, and that's 2007 dollars. That's what we're doing right now every year in the cost of diabetes in this country. Medical impact, it's the 6th leading cause of death. Actually, I think that's a wrong number. That's what's quoted. If you look at death certificate data, which is what they go by, death certificate data basically says, what did they die of? Okay, they died of stroke. They died of heart attack. Due to what? Frequently, diabetes is never listed on the death certificate. So this is a gross underreporting of causes of death. We've tried and we've worked, and again, this is another part of our advocacy group that talked about we need to be better, and we've had a lot of awareness campaign around making sure that diabetes is listed on a death certificate so that we can get the attention it deserves in terms of this epidemic. It's the leading cause of new blindness, ages 20 to 74. It's the leading cause of end-stage renal disease or kidney disease like I talked about. Number 1 cause of dialysis. It's the most frequent cause of non-traumatic limb amputations. okay, other than car accidents. So you've got poor sensation in your feet, you've got poor blood flow to the feet, wounds don't heal, and you end up with amputations. And you're 2 to 4 times more likely to have a heart disease or suffer a stroke. Type 1 diabetes, approximately 5 to 10% of all those diagnosed. It was formerly called juvenile diabetes. It's most common in children or young adults, but we're still diagnosing people with 50 and 60 at times with type 1 diabetes. It is an autoimmune disease. This particular type of diabetes is the body's own immune system generating antibodies against the pancreatic beta cells that destroy those beta cells. You have no insulin production, and the next thing you know, glucoses start to rise rapidly. We know that there is some genetic predisposition to this. We also know that there are environmental factors, and this is an area of significant research right now. How do we try to figure out in families that have clusterings of children with type 1 diabetes, how do we try to prevent this? Are there antibodies that we can look at earlier on? Is there a way to treat the immune system early on to try to prevent these people at risk for type 1 diabetes? And these people usually, if not always, require insulin for treatment and survival. Talked about type 2 diabetes. Type 1 diabetes, sorry. Their complications are primarily microvascular. They don't tend to have as much of the macrovascular complications as our type 2 patients, but they can if they live a long time and have other comorbidities or other issues. Glucose is the toxin, and as I mentioned earlier, we know that we can reduce all these complications by 60% if we can keep their A1C or their glucoses under control. Type 2 diabetes. This is what we are most commonly talking about in this country. It was formerly adult onset diabetes. We changed that too. Here's the disturbing epidemic. It's growing in children. We're seeing 14, 15, and 16-year-olds now in pediatric offices with type 2 diabetes, fueled by an obesity epidemic and genetic risk factors. When I say it's heterogeneous in nature, it means no one patient looks alike. Some of these patients have different risk factors. Some of these patients are thin. Some of these patients are obese or morbidly obese. There is a heavy genetic predisposition to this disease, and it is, as I said before, a pro-inflammatory disease with both the small vessel and large vessel complications. So what are the risk factors for type 2 diabetes? Here's the message we keep trying to tell everyone. Family history, yes. If you have a family history, particularly for type 2 diabetes, you are going to have a significant increased risk. This is what's really fueling the epidemic in this country. And I live in the diabetes belt in the southeast where obesity is a huge issue. And obesity is one of the things that's fueling this insulin resistance and the new onset of type 2 diabetes. We have baby boomers all turning 65 fairly soon. This large number of people is threatening to overwhelm our healthcare system. Physical inactivity, race, ethnicity. We know that people of color have a marked increased risk of type 2 diabetes. I'm going to show you some of those data. African American, Hispanic, Native Americans, Asians, Pacific Islanders. Obviously, as you get older, your risk for diabetes goes up. This is the pre-diabetes. Anyone with blood pressure problems is at risk for diabetes as well. So if you've been diagnosed with high blood pressure, you're at increased risk of having diabetes. And then certain cholesterol disorders, history of GDM, which is gestational diabetes. We know that women who have a pregnancy and have diabetes and have to be managed are at marked increased risk of developing later in their lifetime. And then PCOS, which is polycystic ovarian syndrome, just another sort of insulin-resistant type of thing. Here's some CDC data. Here's the estimated prevalence of diabetes, diagnosed and undiagnosed in people 20 years or older by age group in the year 2007. And you can see here that the vast prevalence, which means how many people in the population have the disease. Okay, we talked about age being a risk, so most of these are 60 plus. So you see 23.8 million people, 10.8 million people in the 40-59, 20 to 39, again highlighting the fact that these patients are a smaller number, but they're growing. So you'd say, okay, well, they're 60 and older. It's just the older patients getting, this isn't quite as bad as I thought. Here's the new cases. The new cases are in the middle of the most productive workforce years, 40 to 59 years of age. This is who's getting diabetes now. So you can imagine that that bar graph is going to change. Look at the increase coming here. So this is pretty alarming. Estimated lifetime risk of developing diabetes for individuals born in the U.S. in the year 2000 what we say at the American Diabetes Association is any child born in the year 2000, there's a 1 in 3 chance they will develop diabetes in a lifetime. 1 in 3. But let me point out a couple of data. If you are an African American female or Hispanic female, it's 50%. And if you talk to people in Native American tribes, diabetes is devastating their population. I don't know if there's anybody here from South Texas, Arizona, where you have these heavy Hispanic populations. It's overwhelming their healthcare system. Many of these individuals don't have good healthcare coverage. They're ending up getting all their care in the emergency rooms, which is a very expensive way to take care of this disease. So, do I have all the answers? No. But, and I'm sure Bill will talk to this, we've got to let patients and the public at large know that this is a serious disease. We almost suffer from the catch-22. If you do really well with your diabetes and you really work and you really manage it well, you can live a long and productive life. And so it tends to make people step back and go, well, this isn't that big a deal. Take your medicine, you'll be fine. Well, that's just not true. It's overwhelming our our healthcare policies. It's overwhelming our hospitals. It's overwhelming our physicians and nurse practitioners' offices. This, I think Bill will speak to, is prevention. We need to get away from just treating the patients when they come in here, and we need to start being very proactive on people at risk and trying to prevent this disease before it occurs, especially in this type 2 population. This is what all of you are here. What do we do? What are our healthcare policies that we're going to develop to try and address an epidemic that threatens to overwhelm our country? And when you sit down in the halls of Congress and you talk to some people, they say, well, isn't this a lot about personal responsibility? Absolutely. But no matter what you believe, this epidemic is not going to stop if we don't do something. And one of the things we advocate for is if you looked at the amount of healthcare dollars spent in research at the NIH compared to the burden of this disease, we don't feel that we're getting our fair share. And then, obviously, we have people in the American Diabetes Association and across the world who are spending their lifetimes trying to find a cure. And we advocate for that and try to support them whenever we can. That's all I have.